the next question is, what novel agents or combinations are you most interested in?
Oh my goodness, I was told that there would be
Dr.
no hard
Brody.
questions at the talk. Great. Novel agents and combinations, I think, is a low-hanging fruit because we are so lucky in lymphomas generally, especially in B-cell lymphomas, to have not only more FDA-approved medicines than any other cancer, including breast cancer, so much more common. We have more FDA-approved medicines than them, but a faster rate of developing new therapies that are successful and have, huge impact for our patients. So I think that the low-hanging fruit for the novel agents and combinations is bispecific antibodies. So we mentioned this great success from the POLARIX trial with Pola-R-CHP, small PFS benefit compared to R-CHOP, especially for the non-GC ABC patients. But the benefit we're going to be having from bispecific antibodies already in the third line, already as monotherapy, and already in combination with chemo, the STARGLO randomized trial, GEMOX plus or minus GLOWFIT, overall survival benefit, gold standard, for oncology trials, already a huge impact. And that's in the third line. But, in 3 years from now, I am saying, or I think many people would agree, that we will have frontline combinations of bispecific plus R-CHOP or maybe Pola-R-CHP that will blow away the results from the POLARIX trial, which, had a significant PFS delta. But the improvements we're going to be getting with frontline bispecifics, I believe, will be awesome compared to what we've seen in the prior many 2 decades of randomized R-CHOP plus or minus X trials. So yeah, bispecifics easily. We have FDA approved glofitamab and epcoritamab already. We'll have a few others coming down the pike. Others that are targeting things other than just CD20, like glofit and epcor, things that are targeting CD79, CD22, CD19, and not just bispecifics, but trispecifics. All of these already have a little bit of data and they look very good. But in the near future, bispecifics plus chemotherapy, already proven to be fantastic in third-line DLBCL, and in the very near future, we'll be using them in frontline DLBCL.
So I'm not going to let you get off easy, right? I want you to look at your crystal ball, and in 2025, what is your speculated regimen, first-line treatment for all patients with diffuse large B-cell lymphoma?
No such thing.
No such thing as a one-size-fits-all, just as Suzanne said. Ruemu, I don't know if you're thinking the distant future, but heads up, 2025 is going to be here in an hour and a half. So it's not science fiction to be talking about it. But no, to be fair, 2025 will still be a split of R-CHOP and Pola-R-CHP with the occasional dose-adjusted REPOC patient as well, and then the mini R-CHOPs and so forth, as Suzanne was mentioning. But we're not going to have FDA approved or even final data from these bispecific frontline trials by then. We might already have some hints from Escalade trial, R-CHOP plus or minus acalabrutinib for non-GC/ABC patients, especially the younger ones. Elderly is defined as whatever your boss is plus 10. So the definition of elderly in the Escalade trial did evolve a little bit even during the trial, but initially I think it was about 65 and under. Now it's about 70 and under. So we might get some R-CHOP plus or minus acalabrutinib data even in 2025 because the trial finished accrual quite a while ago now. And I think that's a very promising trial because the Phoenix trial with ibrutinib was almost positive in that subset of younger folks. So Escalade, acalabrutinib, R-CHOP might be a positive trial even in 2025, perhaps.
All right, Suzanne, I heard you trying to say something. So are you saying 27 then? 27. Okay, what do you think is the regimen?
Sure.
As 2025.
There is
what is the data that will be presented?
Yep, there's a particular trial that's open right now that I find very interesting. So I have to start this caveat by the fact that I'm a transplant physician. And so this is looking at high-risk patients, stage 3, stage 4, and it's giving all patients 1 cycle of R-CHOP. Then they collect their cells for manufacture. They all get a 2nd cycle of R-CHOP and then go on either to finish a full 6 cycles of R-CHOP versus CAR-T. So I think that's a really interesting study. There's no transplant in that algorithm, which I think is nice for patients. So I'm excited for that. But the question will be, which is superior? Obviously, the more cost-effective path is going to win. And so if CAR-T at that juncture isn't better, it'll be reserved for relapse. So I think that will answer not only, practice questions, but also financial questions.
You know what I think is
Dr.
really
Graff.
interesting is that I think we're going to wind up, I'm really excited about what you just said, because I really think it's going to be a combination of, it's no longer going to be our chemo versus our chemo plus. It's going to be bispecific plus versus CAR T. I think our front line in the next, let's just say 3 to 5 years is going to be, you're either going to get a bispecific combination or you're going to get CAR T. And I think our CR rates or our long-term cure rates are going to be much better than 60%. I think they're going to bump. And in that population where we still need to do better, I think they're going to get the opposite of what they got frontline. And I think our chemo is going to be somewhere in outer space. I think with all the novel agents, with Pola, Tafelen, all of the other things that we have in the relapse refractory setting, if our patients are getting bispecific plus versus CAR T frontline, we may never even see a third line again. And so I think that's really the goal with the manipulation of the immune system, and just these T cell directed therapies. And like Josh said, trispecifics, other targets, the CD19s being studied by AZ. I mean, I think, we're just embarking on something super cool with using our own immune systems to do it. So I think it's just going to be, it's going to be awesome. And I think the bispecifics are really going to be the driver. And who knows, is it going to be bispecific for, 2 months, then CAR T, then bispecific, and then that's it, right? We don't really know. But I think the next few ASH, meetings are going to be really cool. I think we're just going to kind of see things build on each other.
So all three of you did mention something, but you didn't really, delve into it enough, which is selection. What criteria do you think we'll be using for selection? Are we still going to be hampered by our current, selection criteria, or do you think there will be new criteria that we would use in identifying these treatment algorithms?
I think the social aspect of selection comes into play. Like, even when I'm having a discussion in the relapse setting about CAR T versus bispecific, a lot of it's not about age or comorbidities. A lot of it's about the patient and what they want, right? Now, CAR T is in theory one and done, but if you don't live near a CAR T center and you have to travel, there's a lot of patients that don't want to do that, right? Or they don't have someone to be with them, or they don't have someone to, take care of them for a month or anything like that. And so I think a lot of it is social. Then there's financial, right? I mean, we know that, bispecifics are off the shelf. There still has to be insurance coverage. I'm not saying that, but CAR T, depending where you are geographically, in the Midwest, we don't have a big issue, but geographically, it's not always readily available either. So I think that's, another thing to consider. So I think, beyond age and medical comorbidities, I think the social aspect, I see the social aspect being a bigger player nowadays, which is interesting. So I think that's going to kind of be on the forefront of those selection criteria. And then obviously the costs and financial aspect. I mean, I'm not sure if everybody agrees, but I think those two things are coming into play more.
Anybody else who wants to make any additional comments on the future and what our treatment paradigms may be? Any additional comments before we go to the next question?
Ruemu, I'll put in a quickie, which is, as we get these fancier and fancier regimens, someone could go backwards and ask, wait, do we need 11 ingredients for some of these patients that had low IPI and they were going to be cured anyway, 90% likelihood, with gentler therapies? And we cannot, unfortunately, look to pharma to do those trials. So you look at like the FLYER trial, for these real low IPI patients, we can give them 4 cycles of CHOP and then maybe 6 cycles of rituximab and get by with absolute non-inferiority. Someone, cooperative group academics, some socialist country in the north half of Europe is going to have to go and do these randomized trials to show, cost benefit of the subgroup of patients. Because, not everyone that would be perhaps eligible for GlowFit Pola-R-CHP in 2027 necessarily would need all of those ingredients. So, we're going to have to go backwards and find how we can risk stratify and get some patients done quicker and easier and still have 90% cure rates. It's kind of like the FLYER trial with just getting less cycles of chemo, maybe giving a fewer less cycles, or maybe less ingredients for some folks. So that's got to get done after these awesome next wave of trials showing in superiority are completed. We're going to have to do some non-inferiority trials afterwards to show who can get by very well with even a little bit less risk of toxicity and also duration of therapy.
Well, the other thing I would add, is that, one of the things you asked is, is there a one size fits all? And so as we look at some of these trials that are incorporating bispecifics or incorporating CAR T early, I really think that they're going to most likely be working with the R-CHOP backbone. I don't see them with Pola, or dose escalated epoch. And so it's a question of how those will be, where will those be in the bispecific CAR T combos? And so I think that'll be an interesting question.